Hello, everyone, and welcome to the 2018 Lymphoma Research Foundation Ed Forum. This year, we are coming to you live from Manhattan Beach for this Ed Forum chat. My name is Joe Messeri, and I will be your host, and we have two very special guests with us today who we will talk about lymphoma with. The first is Dr. Laurie Sen of the BC Cancer Agency, and Dexter Neal, who is a lymphoma survivor and a member of the LRF Ambassador Program. Thank you so much for being with us today, both of you. Really appreciate it. Dr. Sen, I want to start with you. Can you tell us what lymphoma is and how it's diagnosed for those people who might be just getting introduced to it?
Yeah, so, I think it's fair to say that lymphoma is a relatively common cancer, but it's not the most common. So a lot of people, when they're dealing with lymphoma, actually haven't heard the word until they get told by their own doctor. So lymphoma is not just one thing. It's actually a group of cancers that come from a type of white blood cell called a lymphoid cell. So our immune system's a complicated system, but one of the cell types is called a lymphocyte. And when that cancer gets distorted and starts to grow out of control, that's what we call lymphoma. But there isn't just one kind of lymphoma. There are many different kinds. Again, because the immune system's complicated, it can develop different kinds of lymphomas.
And are there causes for lymphoma?
That's the million-dollar question. And, most people that I see with lymphoma say, why me? Why did I get it? And the reality is that in the overwhelming majority of people, we don't actually know the cause, and most likely, based on what we know about the biology, it's probably random bad luck. There are a few things that have been recognized to increase the risk of getting lymphoma, but most people haven't had those risks. So what are those risks? Well, high exposure to radiation, high exposure to pesticides. There may be environmental factors we don't understand. Immune disorders put people at higher risk, but most people don't have those risk factors, and it probably is random.
And so how common is lymphoma?
As I said, it's not the most common cancer, but if you add up all the different subtypes of lymphoma, it's about the 5th most common cancer overall. And as with most cancers, it can affect a whole broad range of ages, but it tends to increase in likelihood as people get older. So from 60 and beyond, the risk goes up.
Now, as you said, there are many different types of lymphoma. Dexter, can you share your story with us? What type of lymphoma were you diagnosed with, and can you take us through what that was like when you first got diagnosed?
Yeah, absolutely. So I was first diagnosed with lymphoma. It was about 2 days before Christmas of 2012, so it made for quite the interesting family holiday. But like Dr. Sen actually brought up earlier, lymphoma was a word that maybe rang a bell to me, but it wasn't something that I was, familiar with at all. I didn't even register lymphoma with cancer. I think I just may have heard the word before, maybe in like a, anatomy class or something. But I was diagnosed with Hodgkin's lymphoma, which is one of the 99 different subtypes that we see in lymphoma today. And it's something that, why it's not the rarest of lymphomas in young adults. It seems to be rather prevalent in that kind of like 20 to 25 age group, and then again in that 70 to 75 age group. But it's not something that me as a 26-year-old man when I was diagnosed was kind of expecting. Yeah. You're not really on the lookout for cancer at that time.
So you said you were diagnosed with Hodgkin lymphoma. We hear that a lot, Dr. Sen. What's the difference between Hodgkin lymphoma and non-Hodgkin?
So all lymphomas come from normal cells that we talked about called lymphocytes, normal immune cells. Hodgkin lymphoma is a kind of B-cell lymphoma. So in the big categories of things, lymphomas can be either B cells or T cells, depending on which kind of immune cell they originated from. So it is a kind of B-cell lymphoma. But interestingly, historically going back, Hodgkin lymphoma looks very, very different under the microscope than the other groups of B-cell lymphomas that we see. So way back in the beginning of time, it was named separately, and interestingly, it's named after one of the original doctors who recognized it, mainly Thomas Hodgkin, and put I don't think he named it per se, but in retrospect, his name was applied to it because he was one of the first people that actually wrote about it. Over the course of time, although we recognize it's a B-cell lymphoma, it has stayed separate as Hodgkin lymphoma, and it is, biologically distinct in many ways and so different that it sort of sits in its own category of B-cell lymphomas.
And so, Dexter, I'm sure when you were diagnosed, all of this science was going through your mind as you heard the term Hodgkin lymphoma.
Yes, I immediately knew all of that.
So, but what was that like when you first heard the diagnosis for you? What was going through your mind?
Well, when the doctor told me, and this wasn't an oncologist, I had seen just a primary care physician, and he had told me that he believes that I had lymphoma, and the first thing that went through my mind was, I use the CVS on 34th Street. If you call in like the prescription there, I'll pick it up and I'll take it this weekend. I'll be fine. I'll go back to work on Monday. And he kind of said, hey, it's a little bit more serious than that. Then we got into the cancer side. And looking at it now, it's almost just this like tunnel vision that I just kind of went into, because you just hear the word cancer and there's one thing that pops into everyone's mind, and it's, am I gonna die? And that's the only thing you could think about, and it's your family, your friends. In my case, I had a daughter at the time. I still have a daughter, but she was 6 months old at the time, and so those are the things that go through my head. From the patient side, I'm not thinking about like what kind of treatment am I doing. That's all stuff that came days later. At that time, it was, how did this happen? Why did this happen? Is this going to be the end for me?
And so, how did you go about telling your family and friends?
So I wanted to tell everyone kind of, in this personal setting, face to face. And I was walking out of the doctor's office, and I took about like 8 steps towards my truck before I had to call my wife. Like, I just literally couldn't handle this like myself internally without reaching out to someone and being able to talk to them immediately. So I told her over the phone, and we talked about it all the way until I got home. And then we reached out to family and friends over the next week or so, and kind of just told them what we knew, which is pretty much like what we saw on a Wikipedia page, when I got home that night. And having someone, like a specialist, like Dr. Sen, somebody like that who can really kind of help you along would have been a very beneficial thing for me, because at that time it was, I have cancer, I'm gonna get treated, I'll keep you updated. And so it's a very kind of scary thing to give out to everyone.
So with that being said, I mean, you mentioned you went into tunnel vision, you needed to talk to your wife about this, and I can imagine it was probably pretty numbing at that time. But Dr. Sen, what questions should patients be asking their doctors about lymphoma?
So, I think it's a process. So what I'm hearing is very typical and very common. I mean, when people hear that they have lymphoma and they understand what it means, generally the body sort of goes into an immediate shock. So I think the questions are not going to just come out immediately for most people with a new diagnosis. But it is a process, and I think number one, you need to have a doctor that you can trust. And lymphoma is such a complicated area of cancer with things changing all the time that, I really would promote everybody to, if they can, see a lymphoma specialist along the way, particularly at the crucial time points when decisions need to be made on treatment. And to get as much information as you can along the way so that you actually know what questions to ask. I think the problem is, when you say what questions, should you ask, most people don't know enough about lymphoma to even know what questions to ask. So, the questions will change, of course, over the course of time, depending on where people are in terms of, a new diagnosis or are they getting treatment. But, the questions are, number one, what type of lymphoma I have, because we already talked about it's not one thing, it's a group of cancers that fall under that umbrella term. And the type is very important. So having a proper biopsy that allows a lymphoma specialist pathologist to distinguish the subcategory of lymphoma is probably the most important thing for every person diagnosed with lymphoma. And that's an important fact to understand, because most people immediately try to reach out onto the internet and start answering their questions from the internet. And if you don't at least know the type of lymphoma you're dealing with, it is overwhelming because there's so much information out there that you might be reading about that has nothing to do with your kind of lymphoma, that, you know, that is very confusing for most people. So the type of lymphoma, how much lymphoma I have, which is usually the next question that doctors will ask, and they'll put people through staging tests to see where the lymphoma is and what stage it's at, and then ultimately, what are my treatment choices? And in all scenarios, there are going to be treatment choices, and the right treatment may not be the same for every person, but every person needs to weigh through what are the options, what are the benefits of one option, what are the risks of that option, and how do the different options compare?
Yeah. With that being said, I want people to ask questions here in this forum. So if anyone has a question, please use the hashtag #EdForumChat so that you can participate, and we will ask your questions to our guests here. With that being said, Doctor, is there a standard of care for lymphoma?
Yeah, so the answer to that is no, because lymphoma is more than one thing. But in almost all cases, so whether or not it's Hodgkin lymphoma or non-Hodgkin lymphoma, non-Hodgkin lymphomas, of course, is a complex group of disorders. Some of them may be slow-growing, some are fast-growing. For each particular lymphoma, there will be treatment choices. For lymphomas like Hodgkin lymphoma or some of the aggressive non-Hodgkin lymphomas that we see, where the goal is possibly to cure and hopefully cure that person of their lymphoma and get rid of it for good, usually our treatments still rely on more than one drug, and most of the drugs include chemotherapies that are, medicines that hurt cancer cells. Now more and more we're combining those sometimes with more targeted strategies, so it's combinations of very often chemotherapy with a more specific lymphoma-directed agent. But there are choices, and in some scenarios there's more than one option to pick from, and they just might have different sort of risks and benefits, so you do need to weigh options. Eventually, although I say for most scenarios we're still using chemotherapy, the sort of pendulum is swinging away from chemotherapy to a certain degree as we get these novel therapies, and I think that for some scenarios we're actually preferentially treating with drugs that are not considered chemotherapy. So there are a range of treatment options, and the right answer is what's right for your lymphoma. But not only that, if there's a series of options, we also need to think about who the person is. So the right answer might not be the same for somebody who gets diagnosed in their 20s or 30s versus somebody who gets diagnosed in their 70s or 80s.
So with that being said, Dexter, what was it like for you when you were diagnosed? How did the doctors go about treatment?
So because of the advanced stage of lymphoma I had it in pretty much all different quadrants of my body, as well as in the bone marrow, my pelvis. Radiation was something that was off the table for me. They told me that if you can't radiate that many spots or you die. I said, or I could get superpowers. They said, no, you would just die. So I did a type of treatment that's fairly common for someone of my age for Hodgkin's lymphoma, which is ABVD, which is 4 different types of chemotherapy drugs. And I did that for 6 cycles, which is 12 different treatments over a period of a little over 6 months.
And when you were going through that, can you take us through what that experience was like for you and your family? Yeah. So going through chemotherapy, it's completely different for every single person, because just like Dr. Sin said, everyone's kind of different point in their life. They're in different physical shape, mental health, age, sex even, kind of determines how you react to it. And sometimes it's just good or bad luck. I felt very fortunate with how I reacted towards the chemotherapy. Usually about 24 hours after I was treated, I would be pretty ill for about 4 or 5 days. Wow.
So 4 or 5 days straight. I did it every Monday. And so by Tuesday through, Friday, Saturday, I was, hurting a little bit. So you kind of go through a lot of dizziness, lightheadedness, hard to focus. Even watching the television or trying to read a book, you get very dizzy and my eyes kind of blur out, as well as a little bit of nausea. I had a pretty bad problem with neuropathy in my hands and feet. which kind of is slowing and cutting off blood flow to your limbs. But then after that kind of downturn, my energy level would start to pick up, and I actually felt really, really good. It was very surprising. So the week after I would have done my chemo, before I started the next one, kind of had like a week break in between, I felt better than I did before I even started my treatment when I was very sick. For a long time I didn't know I was sick, but my energy level was up, the cancer wasn't spreading at that point, it was actually receding, so I felt better.
So you mentioned the pain that you went through. Did you do anything to prepare for that? Did you know about that going in? Was there something that you wish you had known or would have done to prepare differently?
No, I felt very prepared for that. So after my initial diagnosis, I went and we ended up meeting with lymphoma specialists. So we met with some oncologists in Houston this is what they do, and that's what they treat all day long. And they were fantastic. The nurses and the doctors were able to walk me through, this isn't necessarily exactly what's going to happen, but these are things that can happen to you. If you're having neuropathy in your feet, if you're having a hard time breathing, if you're feeling kind of like fluttering of the heart, let us know, give us a call. And they really supplemented my treatment with other kind of medications as well as just vitamins that would really kind of help with those symptoms.
Great. Speaking of treatment options, we have a question from Facebook. Casey asks, and forgive me on the pronunciation here, for brentuximab, am I saying that right? Brentuximab. Is the side effect neuropathy temporary or long-lasting?
Yeah, so we just heard that neuropathy can be a side effect of some of the lymphoma treatments that we use. There's a drug in the ABVD combination that can cause some neuropathy, and brentuximab vedotin, which is now commonly used for Hodgkin lymphoma as a second-line or beyond treatment, and sometimes now being added into frontline therapy, that also has a side effect of neuropathy. Typically, the neuropathy that we see with many of these drugs, including brentuximab, is people will have tingling or numbness, generally in the fingers or toes. So the most susceptible nerves in the body are the smallest nerves, which are really the sensory nerves that go to our digits. And these symptoms, in some situations, they're just bothersome and they're annoying, and people they notice it when they try to pick up or do things that require a lot of dexterity. In the more extreme situation, sometimes people can actually have pain associated with it as well. But in general, when we use these drugs, patients need to tell their doctors how they're feeling, because everybody is different. Some people get it a little bit, some people get it a lot, some people don't get it at all. But if you can sort of track it along the way, sometimes we make dose changes and lower the dose of a drug, which is better not to let it build up too much. But unfortunately, it does happen to a lot of people, and you do treat through it because we expect it to be generally sort of reversible in the end. Most of the time it goes away. Nerves are slow to recover sometimes, so it could take 6 months, it could take 12 months. But I would say that the majority of people have those symptoms go away over time.
You mentioned the term frontline therapies. Mm-hmm. What are frontline therapies and how are they commonly used?
Yeah, so frontline therapy is just a descriptive term for the initial treatment. So when somebody gets a diagnosis of lymphoma, depending on the kind of lymphoma, sometimes they don't need treatment at all. So some of our indolent lymphomas that generally can be treated but not cured, they may not actually need initial therapy. So sometimes the initial choice is just observation. But for most of the lymphomas that we can cure, or for any indolent lymphomas that are causing symptoms, patients will go on to an initial therapy. In some situations, the decision is to pick the best therapy that can cure that lymphoma. If the lymphoma is not curable, basically, it's to pick the best treatment that's going to have the highest likelihood of putting that lymphoma in remission, so that people can feel well not knowing they have lymphoma and keeping that lymphoma quiet. So the answer is there's no one front line. So there are different choices for the different lymphomas that we treat. And even within certain lymphomas, there can be more than one choice.
So you mentioned indolent lymphomas. What's the difference between indolent lymphomas and aggressive lymphomas?
Yeah, so we know that all lymphomas can be categorized based on their biology. So each lymphoma, that we see. Generally, we try to make the best diagnosis in terms of what subcategory it is. So it's based on their pathology or the pathology of the biopsy. But we do use these descriptive terms sometimes, indolent, aggressive, and they're really descriptions of how we expect that kind of lymphoma to behave. And indolent lymphomas refer to a group of different lymphomas that tend to grow very slowly over time. Because they grow so slowly, sometimes they can be there for years before somebody actually knows that they have it. As with all lymphomas, they can travel to different parts of the body. So most of the time, people will get recognized with their slow-growing or indolent lymphoma, and we're going to think of it as a body process. And when it's a body process of a slow-growing lymphoma, most of our treatments can contain it, but they can't cure it. So, it's a situation where people are going to need to sort of live with this perhaps chronically, but the good news is that many people with slow-growing lymphomas are now living perfectly normal lifespans and lifestyles, living with lymphoma almost like somebody would live with a diagnosis of arthritis or heart disease. And my goal as somebody who helps to treat people with lymphoma, particularly if it's one that we can't cure, is to make sure that they go through their normal life not being bothered by that lymphoma as much as we can make possible.
So essentially it may not be cured, but it'll be other causes when they do pass away, not the lymphoma that is the cause of death.
Exactly. My goal as a lymphoma doctor treating with somebody with indolent lymphoma is to make sure they go on their normal life not being bothered or impacted by their lymphoma. So basically, I'd like to blame the heart doctor or the
Right,
lung doctor as their demise, but we don't want to. I think we can safely say that many people, the majority of people with slow-growing lymphomas, is becoming a very, very treatable problem.
So Dexter, when you were going through your treatment, at what point did these terms become relevant to you and start to make sense? Because we hear these terms, indolent and aggressive, and I mean aggressive, obviously a little bit easier to understand, but when did that have meaning for you, and what type of lymphoma did you have?
So when it comes to Hodgkin's lymphoma, and you correct me if I'm wrong, please, but with a young adult with Hodgkin's lymphoma, regardless of kind of whether it was something that you would consider like a little bit more aggressive or a faster growing or slower growing, it's not something that's normally indolent kind of lymphoma, and the treatment's pretty much going to be the same regardless of how you look at it. So I did what at the time was a pretty standard type of treatment. We never really had to get into the specific of it, because regardless of where it's placed on some kind of like nomenclature chart, it doesn't matter, your treatment's the same.
So is that typical of many types of lymphoma, doctor, or does this is this apply to a few cases or many different subtypes when we're talking about indolent versus aggressive?
Mm-hmm. So we talked about Hodgkin lymphoma being a little bit separate from the non-Hodgkin lymphomas, being biologically different and kind of sits in its own category. It's funny, we often don't use the term indolent or aggressive when we refer to Hodgkin lymphoma. The behavior of Hodgkin lymphoma can be different from person to person, but most of the time it often, it could behave indolently, it could behave aggressively, but because it is such a curable lymphoma, that regardless of how it's behaving, the goal in treatment for Hodgkin lymphoma is almost always going to be to come in with the best combination of drugs that we think will cure that person. And ABVD has been that standard for a very long time and is very, very effective for most people. We tend to use the word indolent or aggressive more typically when we talk about the non-Hodgkin lymphomas, because there we've got a much sort of wider group of variety of lymphomas. And before we knew a lot about the biology that we do today that lets us maybe pick the drugs more strategically, we used to focus on, how does that lymphoma kind of going to shift over time, and is it growing fast that we're going to need to react quickly and try to treat this quickly? Is it kind of just smoldering along? And the behavior often sort of indicated what you might need to do in terms of treatment. Now we still use those terms to a certain degree, but we're probably using them less and less because we're focusing more on the individual biological subtypes when we talk about how to treat people.
Dexter, we have another question from social media. Someone asked, did you have any signs or symptoms that let you know you may have been sick? And what initially made you go to the doctor, or what did they see when you went to get checked out?
Oh my gosh, my wife is screaming right now, just yelling at this. Yeah, I had, looking back at it now and knowing what I know about lymphoma versus what I did then, which is, you know, I consider it like quite a lot. Not to a doctor's level, but for an average citizen's level, I feel like I know quite a lot now, and then I knew nothing. So looking back, yes, I had a lot of symptoms. But also, as a 26-year-old healthy man that worked out 6 days a week, cancer's not on my radar. It's not something I'm looking out for. I started with some lumps along my collarbone area, and I know my wife is just yelling right now. And she was like, you should go get checked out. And I was like, no, it's fine. And about a month later, I got some more right here. And then my wife was like, oh my God, you have to get checked out. And I was like, they're very symmetrical. They're probably supposed to be there. And months later, and 45 pounds of weight and muscle loss, and sleeping 12 and 14 hours a day and still being exhausted, I finally went in to get checked out and found out that it was something that I probably could have started taking care of 6 months before if I would have been more informed about, you know, things to look out for.
Yeah. So Dr. Sen, obviously Dexter mentioned the lumps that he felt. What are some other signs or symptoms of lymphoma?
Yeah, so, you know, what I'm hearing is a very, very common scenario, in that because the signs and the symptoms sometimes are quite subtle, it's not uncommon for people to look back and to say, oh, you know, I should have maybe picked this up sooner because now I realize that this was connected. But the reality is, you know, it's not uncommon, because many of the symptoms and signs of lymphoma are very vague, and many of them can be just the kinds of signs and symptoms you might have if you have a flu-like illness. So, you know, sometimes as doctors we often ask, do you have any tiredness, fatigue? Have you had fevers recently that you know, don't know why you're getting these fevers? Are you having some sweating episodes? Are you losing weight, more weight than you know, think you should be losing, even though you're going to the gym 6 days a week? So those are some of the signs, but they're also very vague, right? I mean, you can see many scenarios, or, you know, flu problems where people are going to have those same symptoms. So most people discount them for a very long time, saying, oh, they're going to blow over and they'll go away. Having said that, probably the most common way that people actually get diagnosed is that they eventually notice a lump that is not going away. And anybody who's listening to this today who thinks, oh my gosh, I've got a lump and I have to have lymphoma, the reality is that these lumps are lymph gland swelling. They can occur if lymphoma is there, because they cause lymph glands very often to swell and to be something that you can feel. But lymph glands swell all by themselves in many common normal situations. So when you have a bad cold or an infection of any kind, these lymph glands are there to react to that infection, to protect your body, but then they eventually regress. So, you know, even sometimes what I've also heard is that, you know, I told my doctor about a lump and he said, oh, no, let's just watch it. And the reality is many times that's what the right answer is, because lymph glands swell and regress all the time. That's what they're meant to do. It's when a lump comes up and persists in an, you know, sort of period of time, and then we start to, you know, be clued in, oh, this might be an abnormal lymph gland, and usually prompt somebody to eventually do a biopsy.
So, two directions I want to go from here. First, though, Dexter, I see you smiling and nodding along there at certain parts of the descriptions. What was resonating with you there?
Yeah, well, like a lot of different things. So when I was initially diagnosed, I was living in Savannah, Georgia, which, if anyone's ever been there, it's a beautiful, wonderful place, but it's in the swamp in the deep south on the Atlantic Ocean. And so I remember the doctor was like, you know, have you been having any kind of like sweats? And I was like, I've been sweating since April, like 24 hours a day. So, but yeah, a lot of those symptoms, just like Dr. Sen said, looking back, it's all there. But when you're going through it, you're like, oh, I have a little bit of a swollen lymph node. Maybe it's something that, you know, just I'm kind of fighting off a, you know, virus or something, and that's just part of your body's natural defense for it. And another thing that I was kind of laughing at is when I tell people about, you know, finding lumps in my collarbone, and then my neck, and then in my leg and my arm. As I'm telling everyone, 100% of the time, everyone just was like listening to you, and they slowly reach up and just start feeling around everywhere on their neck. And almost all the time, someone will find something. Oh my God, I feel something. And it's just exactly what you were saying. 99% of the time for most people, it's just your body's natural reaction to your immune system.
So, Dr. Sen, you said a lot of times for that reason, doctors will say, let's wait. Can you talk a little bit more about what active surveillance is? And I imagine everything that goes along with it for both the doctors and the patients.
Mm-hmm. Yeah, so I mean, active surveillance is a term that can mean any number of things. But in somebody who doesn't actually have a diagnosis yet, who comes in with a lump, very often, unless it's something that is so clearly wrong, maybe the size of that lump, how long it's been there already by history, that might prompt somebody to do an immediate biopsy, very often there's a period of, let's just monitor this, because normal lymph glands swell and react to things that even if you weren't sick, they can be reacting to some virus that you didn't even know that you kind of got exposed to. But normal lymph glands also shrink over time. So very often, there might be a period of 3 to 6 months of, let's just see if this goes away all by itself. And that usually would mean that, your doctor would make an appointment for you to come back, whether or not it's a month later or 3 months later. But if it's not going away, or if it's continuing to grow, that usually puts somebody onto the next level, which almost always is to get a biopsy done.
Now,
Dexter, I'm going to guess for you that wasn't the case, given the fact that...
Yeah, well, that's what I was talking about with my wife. Probably, and she will not let it go, but maybe hundreds of times told me I needed to go get checked out, because by the time I actually went in, I had a golf ball sized, tumor on my throat, and then one on each side of my neck where I had these kind of Frankenstein bolts sticking out. And like I said, I didn't know what lymphoma was, so it wasn't. I was just sitting there thinking something's swollen, and I was like, maybe I have mono. I'm really tired, and I lost a lot of weight. And I've got these, swollen. I didn't know there were lymph nodes. I was thinking, where's the thyroid? Is that a thyroid thing, maybe? So it wasn't something that even crossed my mind.
I want to ask you, through your work as an ambassador for Lymphoma Research Foundation, I've heard a lot of patients refer to the active surveillance as watch and wait, or wait and worry, depending on how you hear it. In your experience, have you had people share those stories with you of the anxiety that they go through while they are waiting? And if so, how has the Lymphoma Research Foundation helped in those instances?
So the first few years I was involved with the Lymphoma Research Foundation, I talked to hundreds of people, if not thousands of people, and I heard a lot of different stories about that. People who were kind of in that watch and wait program before they started treatment, people who were currently in it and haven't had any treatment, or people who were doing it afterwards. And just like with anything, people are so diverse, and everyone kind of reacts and deals with that differently. But it ended up becoming something that I actually even had to do about 2 years ago, when I went in for just a scan, and we had some new growth that was found in my chest and in my abdomen. And we ended up kind of just saying, hey, it's not huge, let's wait and watch. And there is a lot of mental anxiety just associated with that, because it's this thing that I'm just laying in bed every day, and I'm going to work every day, and I'm going, is there just a tumor growing in me? And I'm thinking to myself, should I not eat this food? Do I need to go get some kale? What can I do? But so it's just a constant thing. It can very, very much interfere with your everyday life.
And so when it comes to people who you've spoken to about lymphoma, how important has the Lymphoma Research Foundation been to you and your family throughout this process?
I say this a lot, and it's absolutely true. It has been probably the most important thing that helped out my family, which in turn helped me more than I could ever express. being 26 years old, diagnosed with blood cancer, and you're looking at less than, it's like almost 0.5%, I believe, of cancers in the United States are 20-something-year-old kids with lymphoma. So it's a very small group, and it's not people you just know, you can go and talk to and kind of find out in the street and figure out what they went through, how they dealt with it. Let's look at them coming out the other side. And it's just this kind of hopeless and helpless feeling to where you feel alone. You're just on this island by yourself, and everyone's just looking at you and trying to figure out what's going on. And when we ended up hooking up with the Lymphoma Research Foundation through just like a local fundraiser, a walk in Houston, we walked into this place where we were completely alone for 4 months, and we saw hundreds of people from around like the greater 4 or 5 state area that came to Houston to be a part of this this community that we formed. And being able to see my mother and my wife and my sister talk to people who've gone through something similar, whether it was Hodgkin's or not Hodgkin's, doesn't matter. But they had their stories, and we see them now, living, thriving, and surviving, and coming out the other side. You could visibly see a change in the way that my family treated me and talked to me, and this hope that they had that wasn't there before. So being part of and seeing things through the Lymphoma Research Foundation was the greatest thing that happened to me with my treatment.
That's awesome. Dr. Sen, from your point of view, how beneficial is having that community for patients when they're going through treatment?
Oh, I think it's hugely beneficial. I think there are so many hard things about having lymphoma, of course. It's just like any cancer. The good thing is that lymphoma has such a good outlook for most people, but it's still scary. And part of the scary thing is this lack of sort of knowing what the future holds, or the lack of knowing what the options are. So I think, the Lymphoma Research Foundation offers not only this network of support and people that, serve as a great resource of information, both from the technical to the personal side. But I think one of the hardest things is it's hard for people to navigate all the information out there. So just looking up information randomly on the internet, I think, is overwhelming and leads to more anxiety. What we want is for people to get the information they need in a way they can digest it, process it, where it's valuable to their situation, because that's what lowers anxiety, and that's what lets people make the right decisions for them as they go through their treatment. And I think, the support services through the LRF just help to do just that. It's a way of sort of getting the information you need in sort of relevant sort of chunks in a digestible way. And I can't commend the organization enough in terms of what it's had to offer to lymphoma patients.
Right. You mentioned all of the wealth of information that is out there. I want to do a little bit of a reset for people who might just be joining us because they come and go on social media. But you are now watching the Ed Forum chat from the Lymphoma Research Foundation. We are coming to you live from Manhattan Beach, and we are discussing topics and issues surrounding lymphoma, all the different types. We have with us again Dr. Sen from the BC Cancer Agency, and Dexter Neal, who is an ambassador for the Lymphoma Research Foundation and a lymphoma survivor himself. And so we're doing a good job spreading some information because we have some more questions coming in from social media, which is great. So Dexter had mentioned a little bit about adolescent and young adult lymphoma. So Dr. Sen, is this cohort treated differently than the rest of the population when it comes to treatment of lymphoma?
Mm-hmm. Yeah, so lymphoma can affect people at all ages, and all the different types of lymphoma can affect people at all ages. Although specifically speaking, in terms of adolescents and younger adults, there are some lymphomas that are more commonly seen in the group of people, and particularly Hodgkin lymphoma tends to be a much more common diagnosis in adolescents and young adults. So in terms of the types of treatments that people are getting, they can be more frequently seen in that group. But I think, even if you're getting the same treatment, the experience is very different as an adolescent and a young adult than it might be as somebody who's older. So not only are we worried about treating the lymphoma and giving people the best treatment that they can get to cure their lymphoma or control it as best as we can. We also need to think about in adolescents and young adults what side effects these treatments might be causing, what side effects they might not just have now, but 10 years from now that we want to prevent. So the thought process is different when you're dealing with somebody who we expect is going to go on to live 50 or 60 more years at least, than somebody in their 80s where, the concerns might be more immediate. So I think there are many different things. There may be some differences in the lymphoma biology, but the treatment implications are different in younger adults and adolescents. And, I think the social experience is very different as well.
So, Dexter, when you were going through this, once you got past that, am I going to die question, what were some of the main concerns you had as a young adult, 26 years old?
Yeah, so over the am I going to die? What's my treatment? Where are my next steps? Where am I going? Who's my oncologist? That stuff's taken care of. I'm going in. I'm about to start my first treatments. My big thing is, what kind of side effects am I expecting? And what are my long-term, kind of side effects and things that I can anticipate, specifically like fertility. It wasn't something that I ever thought about with cancer before, because I associate cancer previously with, 70-year-old men and women who usually aren't so worried about children, having children at that age. So that was something as a young adult that I think is a very big fear that's a lot different than someone who's diagnosed much later in life. And there are different treatment options and different ways to kind of go about treating your lymphoma that give you better odds and outlooks for future fertility, whether you're a male or a female.
Were you able to express those concerns to your doctor?
Yeah, I did.
Yeah.
I did. I kind of like to joke about things like that, so
We haven't noticed.
Yeah. So I expressed it to him in people might call it crass way, but he got the point, and we were able to really work together to kind of have a good idea and a plan of what we could do and what we could put in place to make sure that I had the highest percentage chance of coming out the other side fertile.
Were you able to get there on your own? Did it take some soul searching to think about the longer term effects? Because as you mentioned, you got the immediate needs taken care of and out of the way. What was it that helped you get to that next level thinking and thinking about your life and wanting to plan for it as you were going through treatment?
Fear. Really, it was fear. Because I'd left Savannah, Georgia. I'm in Houston, Texas. I've got an apartment. I'm about to start my treatment, and I'm just sitting there all day for a couple weeks. And it's that fear that is just constantly running through my head. What's going to happen? How am I going to react? What am I going to do? Where am I going to get help for these things? The fertility question wasn't actually something that came to my head. That was something that was brought to my attention by my oncologist, so that was great. For me, it was more of like the other kind of side effects, whether it was, short term when it comes to nausea due to chemotherapy, or long term effects that could be physical or mental or like internal when it comes to heart defects, lung issues, liver problems. These are all side effects that worried me, things that I thought about, things that I'd read about, and things that I'd spoke about with my team.
So, Dr. Sen, Dexter mentioned that his oncologist initially brought up the topic of fertility. When it comes to that doctor-patient relationship, how important is it that patients are fully communicative with their doctors? Because I imagine that it might be hard to talk about. It might not be the thing that's on the front of their mind when they're dealing with the immediate lymphoma diagnosis.
Mm-hmm. So, I think communication is extremely important, and, probably not all doctors do as good a job as communicating sort of the broader issues to their patients. But, you need to be comfortable to speak with your oncologist or the doctor that's looking after you to raise all of the issues of concerns, and it really is probably the oncologist's job to make sure that you're aware of all the concerns that that you need to be aware of. As Dexter said, he wasn't even thinking about fertility as a concern he might need to have. So, there are lots of implications of treatment or the diagnosis itself that, are either immediate or even delayed that just really should become part of the discussion as treatment choices are made. And I think most of us do our best to raise all these issues. The problem is that you can only take in so much information. And, most people, when they're faced with an immediate diagnosis of something very threatening like a lymphoma, they're focused on the immediate concerns. This is, what do I have to do to get rid of this? Right. And the side effects are, yes, I need to know about the side effects, but I can deal with a lot of side effects if you tell me this is the best treatment for me and this could cure my lymphoma. So, most people are most concerned about getting the best treatment, and then they want to hear about the side effects. Most people are not thinking long-term right away, and that's sort of, conversations that happen over the course of time.
Dexter, that touched something in you. Was there a specific moment that came to mind?
Well, yeah. I mean, when you're sitting there, you're talking to your oncologist and say, hey, this could have, in 30, 40, 50 years for you, this could lead to like a higher chance of heart disease. I'm like, oh no, in 40 years I could have heart disease or I could die next month.
Right.
You don't care. Neuropathy in my feet that I deal with 5 years later. It doesn't bother me because I have a 6-year-old daughter that I get to see every day. That just because my fingers twitch and my toes tingle, that's nothing compared to what I could have lost versus having tingly feet.
When you talk about that somewhat of a lessened concern for the side effects that go along with this, just the priority being on the best treatment. I know a lot of patients have questions about clinical trials. So, Doctor, I want to start with you first. When it comes to clinical trials, what questions should patients be asking their doctors, and why are those trials so important for lymphoma research and treatment?
Mm-hmm. So, we already have many treatments available for people with lymphoma. And, we know that there are different kinds of lymphomas, and the different kinds of lymphomas are treated with different kinds of treatment. In some scenarios, we're able to cure those lymphomas. And, whenever we have a best known curative treatment, well, that is usually the logical treatment of choice. But in many situations, we may be in a situation where there are several choices, or those choices are not going to cure the lymphoma but control it. So there are many situations where we need to get better drugs, or we need to get drugs that are as good with less side effects. And so there's a huge need to continue to develop novel therapies for lymphoma. How do we develop novel therapies, and how do we get a new drug on the market? Well, there's a very careful process that a drug has to go through to get on the market, and that's very careful testing to prove, number one, that it's safe, and to prove, number two, that it works. And the clinical trial process is that process to test a drug so that we can get it out there so that people can use it. I think clinical trials are extremely important, and they're an opportunity for patients to actually get access to what could be very effective treatment years and years before it actually makes its way onto the market. So, I think in any situation where treatment choices are being discussed, you should always be asking your doctor, is there a clinical trial here that might be right for me? And let's discuss that along with all of the other treatment choices that I might have at this time, so that, I can weigh in whether or not that should be my next step.
So did that play in for you at all, Dexter, as you were going through your treatment? Were there any clinical trials that you were either aware of or actually participated in?
Yes, so there were some clinical trials going around at the time. I believe it was like rituximab. This was 2013. I ended up not being a part of a medicinal clinical trial. I've been part of like a research study that has more to do with like the mentality and psychology long-term of cancer patients, and I'm still doing that 5 years later. But I did not participate into a clinical trial, but I was made aware of different options and things that were out there that I could have done.
So when you're going in, I imagine when you hear about the potential of certain trials and what they think these drugs might be able to do. As a patient, does it get your hopes up? And if they tell you you're not able to participate in that trial, how does that work?
Yeah, so when someone sitting there is telling you, hey, there's a clinical trial out, it's for this certain type of drug, it essentially does the exact same thing of killing it, but it doesn't hurt you as bad. And you're like, let's
Sign
do
me up.
that.
Right.
And then we're going, oh, no, never. Right. And it wasn't like that. I wasn't denied or kicked out or anything. It was something that my doctor and I discussed, and we decided not to go into that together because we wanted to be able to start my treatment sooner rather than later. And unfortunately, when it came to the timetable for that clinical trial, we were still a few months out. And so we decided to go ahead and start our treatment sooner.
So, I mean, I would just pick up on that point, and that, you know, sometimes a clinical trial is the right thing, and sometimes it may not be the right thing. There are factors that, you know, that might convince somebody that, you know, yes, they want to participate on the clinical trial, or factors that might make it, you know, difficult to do so. I think the most important thing is, you know, is that people are aware that these clinical trials are ongoing, that it might open up an additional opportunity, and I think people should just be aware of all their opportunities. It's not always going to be right, and you know, the expectation is not, you know, if you're asking about clinical trials, that you have to go on to one. These are voluntary choices, but I think that it should be kind of the logical next question after, you know, what are my standard treatment choices? Is there a clinical trial out there that is an extra opportunity? And, you know, let's discuss where that might weigh in terms of my choices.
And when it comes to the participation in these trials, obviously expanding the research for lymphoma, why is that research so important?
You know, I cannot stress enough how much things have accelerated, for example, in the last 10 years. So there are drugs on the market now for lymphoma that weren't there 5 years ago, 10 years ago, that we can tell are making huge strides of benefit. So, you know, for many lymphomas, the cure rates have gone up. For many lymphomas, the control rates have gone up. You know, outcomes are just getting better and better, and that's a consequence of these novel drugs coming out onto the market through the clinical trials process. So, you know, I think we're just seeing things exponentially improving, both in terms of our understanding of lymphoma biology, which is now translating into these new, what we call, you know, often I've heard people call them smart drugs, and they're smart drugs because they're based on biology. First, we recognize what's driving the lymphoma at the very biological level. Then we can actually design a drug that is able to stop that specific part of biology that's causing those lymphoma cells to grow. So, you know, we've got a whole series of targeted agents that have been developed, and, you know, we want to get these drugs out faster where people can use them, which means, you know, anybody who sort of participates in a clinical trial helps to get a drug out there faster.
So what's the biggest difference between clinical trials and standard care then?
Yeah, so a clinical trial is generally a careful way that drugs are tested to sort of prove, number one, that they're safe, and number two, that they're effective, and then very often to compare them against the standard of care. So, you know, drugs, essentially everybody's goal is the same thing. Let's make treatments better. And the step one is to create a drug that might be very different from a drug we have right now. We want to prove that it's safe, we want to see that it works, but ultimately we also want to show that that's better perhaps than what we have, so that we can start preferentially using it. And a clinical trial is just a careful mechanism for being able to take a drug through that process. So a clinical trial is sort of a process where people will be receiving a treatment that may not be out there on the market. Or, you know, it could be actually a drug that is out there on the market, but it might be out there on the market for leukemia, or it might be out there on the market for a different kind of lymphoma. And now they're trying to investigate whether or not it's helpful for your kind of lymphoma. So I shouldn't mean to imply that these are always experimental agents. Sometimes they're, you know, safe drugs that are on the market. It's just that we're trying to find, you know, other situations where it may be helpful. But it is a, you know, in most cases, clinical trial is asking a question, and the questions it's asking is, you know, is this drug safe? Is it effective? And where should we use it? Who is it going to help?
You mentioned all of the progress that's come from that. from the research and the trials. For either of you, is there something on the forefront in lymphoma research that has either of you particularly excited right now?
Yeah, sure.
Go ahead.
Yeah, so I'm obviously not a doctor.
Right.
I'm not a researcher. This isn't, my forte. If you guys want to know about like the Skywalker family or something from Star Wars, like I'm your guy. But I am part of the Lymphoma Research Foundation in kind of this representative role, and so I do get to meet a lot of physicians and a lot of researchers and see things that they're doing. And one of the coolest things for me is seeing what we're doing with personalized treatment options. And so it's something just like Dr. Sin was talking about, where they're going to like a microbiology level, to like the smallest level of the cell and the atom, and how it reacts differently. So if you and I, Joe, had the same kind of lymphoma and the same treatment, they could sit there and look at it and say, hey, Joe's genetic makeup is a little bit different than Dexter's, and so they're going to react to this specific drug differently. And these are things that physicians are researching with the money raised by the Lymphoma Research Foundation, to where they can have this personalized level of care that is mind-blowing to me. It reminds me of like the Magic School Bus TV show where they just shrunk the bus down and they went through the bloodstream, and they, that's almost where we're at now when it comes to targeted medication for individuals.
So when you meet with other survivors or people who are currently fighting their battle, does that get you guys pumped up? Is there talk and buzz about that? Did you see, are you saying, did you see this? Are you hearing about these new things?
Yeah, we absolutely talk about that between all of us, whether you're going through it still or we've beat it. And it's a very exciting thing, and it's also a very personal thing for me, not just as a survivor, but as someone who was diagnosed with lymphoma as a young adult. My percentage chance of developing later life cancer is nearing 100%. Most likely I will be fighting either lymphoma again or another type of cancer that I'm going to have in my lifetime that most people don't. And so even though I'm in remission, I'm not currently fighting, I know that one day in the future I probably will be. And so seeing these kind of advances and seeing what medicine and the research money is doing is something that does give me like a lot of long-term hope.
Great. And how about for you, Doctor, from the research side of it?
Yeah, so I would definitely echo, what Dexter just said, that personalized medicine is where we're all striving to get to. And, we've talked about some of the targeted therapies and those smart drugs. Well, the smart thing is to pick the right drug for the right person. But I think the other big area that really is catching everybody's attention is immunotherapy. So at the very basic level, lymphoma is an immune cancer. And, there are a number of novel immune type remedies that are being developed that are having huge impact on treating certain lymphomas. And I think we're only sort of at the very beginning of exploring the potential for immune therapy. So I think that many of us are really excited about the long-term potentials of the different kinds of immune therapies that are being developed.
That's excellent. So with that being said, I want to end with this for both of you. What advice or information, what would you just say to someone who was newly diagnosed with lymphoma? And Dr. Sam, we'll start with you.
Yeah, so, regardless of the type of lymphoma, I guess I want to reassure people that there are many treatment options, that it's an exciting time where, newer treatments are coming out all the time, and those will have real impact for real people, in the immediate future. I think it's important to get as much information that you can, so that, information is empowering and it relieves a lot of the anxiety around the unknown, but having a strong team around you to help. I mean, nobody's doing this alone, or nobody should be doing this alone. So creating that team of people that are going to support you through it, having, an oncologist that you can trust, a lymphoma specialist, because I think it is a very specialty field, having the support network of, friends and family around you, and the support network of people through the LRF that, through personal experience, can actually provide a lot of information and a lot of support.
Excellent. Dexter?
Yeah. Can I talk to the camera?
Absolutely. Go ahead.
So, if you're currently struggling, if you're fighting the good fight against lymphoma, if it's your son, your husband, your wife, your daughter, your grandchild, your mother, it doesn't matter. If you're personally touched by this and affected by this, the one thing I tell people, every single person, is you have been drafted into a community that you never wanted to be a part of. None of us did. No one wants to be here, but here we are. And the thing is, it's not just you. There's thousands of us, and we're all here under this umbrella of the Lymphoma Research Foundation. We're here to help you grow, to survive, and to thrive, and we're a community that's going to support you and be here with you. Please, whether it's on, for yourself or on behalf of someone else, reach out to us. Don't fight this fight alone, because it's a lonely and it's a scary place to be. It's something that we can kind of help you through, and it's a great thing to be able to help someone and help watch them come out on the other side. And so please just reach out to someone. Don't try to kind of just handle it yourself.
And it is truly amazing to see at this year's Ed Forum that come to life. And they do this every year on one of the coasts. As I mentioned, this year we are in Manhattan Beach in California. But Dr. Sen and Dexter, thank you so much for being a part of this Ed Forum chat today. You can still continue to ask questions on social media. And of course, don't forget to check out lymphoma.org for all of this information. Please like, share, and spread this information as much as we can, because ultimately, if we're going to cure lymphoma, it's going to take awareness and the dollars that go into the research. So thank you so much. Thank you everyone for watching, and make sure you go to lymphoma.org for more information.